Good morning, everyone. And my name is Ola Bicietti with Franklin County Public Health, and we welcome you to the ACEs, PACEs, and Addiction Summit. Before we begin, I'd like to go over a little housekeeping. Disclosure statement. There is no conflict of interest for anyone with the ability to control the content of this summit. For those of you seeking continuing education credits, applications have been submitted to the Ohio Chemical Dependency Professionals Board and the Ohio Counselor, Social Worker, and Marriage and Family Therapist Board. 1.5 credits are available for the keynote presentation only for those seeking CHESS credits. Attendees must sign in no later than 10 minutes from the start of the keynote session. To be eligible for any and all CEs that are pending approval, please submit an application, the link of which is located on the slide and will also be available post-session via email. All attendees must attend at least 90% of the summit, excluding the lunch hour. And please complete the evaluation within 1 week of the summit. That would be the deadline of October 26th at 11:59 p.m. in order to receive any credit. Once again, this information will be available via email at the conclusion of the summit. For those of you with smartphones, we have a QR code available for you to scan as well. And with that being said, I will hand it off. Oh, yes. I will now hand it off to our wonderful leaders within Franklin County to welcome you officially to the summit. Thank you, everyone.
Good morning. I'm Franklin County Commissioner Kevin Boyce, and welcome to the Franklin County Public Health ACEs, PACEs, and Addiction Summit. Throughout the day, you will explore how addiction rooted in adverse childhood experiences, both in personal and community levels, is being successfully mitigated by protective and compensatory experiences. These PACEs are shown to help reduce the effects of adversity and build resilience in improving our chances at treating addiction through interventions in children and adults who have experienced ACEs. We know this last year has brought an unimaginable levels of trauma in ACEs, as well as increasing levels of addiction throughout our community. Symptoms of the pandemic that preyed on the most vulnerable residents at their most vulnerable moment. But thanks to the work of our tireless public health professionals, we're making great strides at understanding what impact the science of early life adversity, lifelong resilience, and related intervention and prevention programming will have on those suffering from ACEs and how we can better treat the next generation. It's through conversations like these and gatherings like this that we can begin to repair the trauma to our community and help build a stronger Franklin County for all of us. Thank you so much for joining us today.
Hello. I'm Franklin County Commissioner OGrady, and I'm grateful to join with my colleagues in welcoming you to the Franklin County Public Health ACEs, PACEs, and Addiction Summit. As a father of 4, I know how important it is to ensure our children growing up knowing that they're loved and valued. Children who know they matter to their parents and guardians begin building a strong, steady foundation for lifelong well-being at a young age. And while mattering may in itself not be an ACE, research shows that the most common denominator for supporting a child's well-being is at least one stable relationship with a supportive parent, guardian, or other caregiver. Sadly, in Ohio and here in Franklin County, many children are not getting the support they need to thrive. With almost half of those under 18 in our state experiencing one or more ACEs, over a third experiencing between 1 and 3, we know we must do better with our children. In Franklin County, almost 10% of our children report violence in their home, and 13% report living with someone with a co-occurring substance abuse disorder, Those ACEs alone often cause irreparable harm, furthering a cycle of abuse and poverty that can be perpetuated across generations. But studies show that using protective and compensatory experiences, or PACEs, are breaking through and successfully treating children who have experienced ACEs. In Franklin County, we know something about confronting difficult and often irretractable generational problems. Whether through our community-wide efforts to address poverty with the Rise Together blueprint, or our declaring racism a public health crisis, we aren't afraid to tackle the problems that plague our community. Your commitment and your work today will help us on our journey to making a better community for all of our kids. We can do big things in Franklin County, so let's get started together. Thank you.
Good morning. I'm Franklin County Commissioner Erica Crawley, and I'm honored to join you today at the Franklin County Public Health ACEs, PACEs, and Addiction Summit. As a mother, veteran, and an individual who regularly confronts mental health challenges as I experience depression and anxiety, I am grateful and moved that such a dedicated group of professionals is gathering today to address some of our community's most pressing issues. We know adverse childhood experiences are strongly related to the development and prevalence of a wide range of health problems throughout a person's lifespan, including those associated with substance use disorder. In 2020, here in Franklin County, 22% of children removed from their homes by Children's Services were due to parental substance use abuse disorder. Over the last 7 years, we've seen a steady 16.5% climb in the amount of children being removed due to parental substance use abuse disorder, a multi-generational trauma that can cause a cascade of further ACEs. On average, a greater proportion of Franklin County residents are living in poverty and without health insurance than other Ohioans, and children in Franklin County are at greater risk of living below the poverty line than adults. Ohioans with low incomes are more likely to report exposure to 2 or more ACEs. When children are exposed to chronic stressful events, their neural development can be disrupted. As a result, the children's cognitive functioning and/or ability to cope with negative or disruptive emotions may be impaired. Over time, and often during adolescence, the child may adopt unhealthy coping mechanisms such as substance use or even self-harm. From 2009 to 2019, there were 56 deaths by suicide among Franklin County residents under the age of 18 years old, and nearly 34% of these deaths were among children 14 years or younger. Utilizing 14 years of suicide data, researchers from NCH found that Black youth ages 5 through 12 were nearly twice as likely to die by suicide than their white counterparts. It indicated that Black youth have experienced a significant upward trend in suicide from 2003 to 2017, particularly among 15 to 17-year-olds. The CDC recognizes that living in a community with high rates of violence and crime increases the risk of an individual experiencing ACEs, and also recognizes community violence as an ACE itself. Beginning in 2020, the violent crime rate in Franklin County increased dramatically, constituting a 2-year increase since 2018 of 18%. We know we must do more to stem the tide of addiction and substance use disorder, of poverty and negative health outcomes, and neurodevelopmental disorders and suicide attempts. Our work is rooted in better understanding how to use PACEs, interventions, and other treatments, being intentional about deploying successful strategies in communities of color, in communities with increasing violence, in communities with high rates of poverty, and in communities that have a history of negative health outcomes. As we strive to serve every resident every day, we must take care of our most vulnerable first. We can do this, and we must do this for Franklin County and for each other. Thank you.
While the COVID-19 pandemic has been difficult for everyone, it's been especially challenging for those battling the disease of addiction. As a Columbus Health Commissioner, I am grateful to all of you for joining us for the ACEs, PACEs, and Addiction Summit. We appreciate your support and engagement and commitment to this important effort. Events like this one are important because they bring critical partners and people together to address the addiction crisis, which has grown worse during this once-in-a-lifetime pandemic. Together, we can learn more about the importance of connecting adverse childhood experiences and the protective factors with substance use disorders. When we understand and address this, we can begin to fully impact the addiction crisis in our community, beginning with our youngest residents. Columbus Public Health is proud to lead the Columbus and Franklin County Addiction Plan, which is working with many community partners to address the addiction crisis right here in our community. The work is enhanced by the Columbus Public Health Addiction Services team, as well as our CARE Coalition, which is working to build a resilient and trauma-informed community. When we understand and address adverse childhood experiences, we can work to prevent drug use among our community's youngest and most vulnerable residents. When we build stronger youth, we build stronger communities and help prevent drug use before it even starts. Thank you again for being here and for working with us to address the addiction crisis in our community.
I'm not sure what to do with this screen, so someone's going to have to help me on that one. But good morning, everyone. Good morning and welcome. Welcome to the ACEs, PACEs, and Addiction Summit, exploring the roots of addiction and adverse childhood experiences. My name is Joe Mazzola, and I'm the Health Commissioner of Franklin County Public Health. And on behalf of our Franklin County Board of Health, the Franklin County Board of Commissioners, and Dr. Mashika Roberts, I want to welcome you all to this very important conversation. Thanks for joining us here in person. And for those online, thank you also for joining us as well and giving up your day for this important discussion. As we've heard in some of the welcoming comments, the current trends we are seeing in our community and what our children are experiencing as a result of the pandemic and poverty is cause for alarm, and thus the need for us to be here today. And that's really what today is all about. Today is about a conversation. It's about a conversation, it's about dialogue, it's about collaboration, and most importantly, it's about action. Today is about changing and elevating this conversation as a community, and I'm so grateful that so many of us have decided to take this opportunity. And I think last count, someone told me 380 total joining us here, both not in person. I think we had 60 or 70 here in person, but to just really think about that, 380 people have dedicated to the day here to join this conversation. And just for a little perspective, our state public health conference that we host every year has about 330 for a statewide conference. So thank you to all of our colleagues here in Franklin County and across the state who have joined us here today. ACEs impact all communities, but they do impact some more than others, as we have heard in the opening comments. And so we have to be sure to take an equitable response to ensure that intervention and prevention efforts focus on where they need to be and make sure that we reach those who are most disproportionately impacted. We're going to hear more about that here later in the day here today. But whether it's abuse, neglect, household changes, or other adversity, we understand children who experience ACEs are at a greater risk for not finishing high school, gaining employment, are more likely to smoke, unintended pregnancies, and generally have poorer health outcomes. And so we need to make sure that we stay focused on ACEs here as a public health issue. These policy systems and environment that our community must not only create the conditions to limit the number of ACEs, but also to make sure that we support those PACEs, or those protective and compensatory experiences. As a community, we need to align our planning efforts to support these policies. And I'm very grateful for the fact that we're already doing that here in Franklin County. It was mentioned the Columbus and Franklin County Addiction Plan. We also have the Rise Together Blueprint to address poverty. And of course, our Future Ready by 5 plan, Future Ready Columbus's efforts. And of course, our Community Health Improvement Plan as well. And so collectively, we need to continue to align our planning here in Franklin County. Franklin County Public Health has partnered with multiple community organizations to implement evidence-based interventions that focus on substance use disorder and have simultaneously identified ACEs as an early indicator to the addiction crisis via our CDC Overdose Data Action Grant. We believe the alignment of these two areas has significant potential to bring tangible public health benefits to our community. And as we move into 2022, I'm very, very grateful for the fact that we are working with Columbus Public Health and our 4 adult hospital systems on our next community health assessment, which will really be a guiding document for all of our work as we move forward as a community. The topic of ACEs is a difficult conversation. I can say personally, I've experienced several ACEs in my life, and I know that I'm sure many of you have also had similar experiences. So this is not just a professional conversation, this is a personal conversation for many of us. But it's a conversation that needs to be had today, and it's a conversation that cannot stop today. There's so much good work happening in this community, and we're going to hear from many of our partners about that work. We need to ask ourselves tough questions. We need to challenge what's happening here in our community. We need to hold ourselves accountable. We need to talk about what needs to change in our community. And I think we have the leadership from across our community and across all of our organizations in order to do that. I mentioned our community health improvement plan, and that our plan really focuses on alignment. And the centerpiece for that community health improvement plan is around social determinants of health. And it also centers around the idea of hope. This conversation will help instill more hope in our community. And I'm very, very thankful for that. It's what today's all about: a stronger, more resilient community, a more hopeful community, and ultimately a healthier and more thriving community. So with that, I want to say welcome. I want to say thank you to our planning committee. You'll get to meet them over the course of the day. You probably already met some of them already. This really is a remarkable event that came together in not a lot of time. And I want to thank everyone who's been involved with it. Truly a remarkable effort to bring all of us here together this morning. So with that, I'd like to now introduce our keynote speaker here this morning. Dr. Roy Wade Jr. is an instructor of pediatrics at the University of Pennsylvania and a general pediatrician at Children's Hospital of Philadelphia, Cobbs Creek Primary Care. Dr. Wade has a PhD in microbiology from the Georgia Institute of Technology. He received his medical degree from Dartmouth Medical School, completing his pediatric residency at the University of Virginia. After residency, Dr. Wade completed a Commonwealth Fund Harvard Minority Health Policy Fellowship at the Harvard School of Medicine and Harvard School of Public Health, earning an MPH in Health Policy and Management. He completed a Robert Wood Johnson Foundation Clinical Scholars Fellowship at the Perelman School of Medicine at the University of Pennsylvania. His research interests focus on the intersection between childhood poverty, adversity, and well-being. His work focuses on translating research on the science of childhood adversity and toxic stress into effective strategies to improve community-level systems of care in economically distressed communities. We simply could not have someone really more knowledgeable, an expert across the country to really give our keynote here this morning, and we're so honored and grateful to have him. Would you please help join me welcoming Dr. Roy Wade.
So okay, I'll put this on. Thank you. How are we doing? Good morning. Thank you to your esteemed health commissioner, to your board of commissioners, Office of Public Health, and your planning committee for inviting me out today to talk to you about ACEs, resilience, and the opioid epidemic. I'm a pediatrician, a general pediatrician, but I spend most of my time doing research around the impact of trauma on the health and well-being of kids across their life course. I'm going to talk to you about some work that I've done today in collaboration with some colleagues in Philadelphia to take the initial work from the Adverse Childhood Experience Study and translate it into practice. I'm hoping to leave you with some ideas around what you guys can do here in Franklin County to impact the opioid epidemic by addressing what I think is one of the early roots of this epidemic. So with that, with no further ado, I'll start. I hope you guys don't mind. I'm going to keep my mask on because I like to pace. I can't stand standing still. Pardon intended there. So the title of my talk is The Opioid Epidemic, Understanding the Role of Adverse Childhood Experiences. To give you guys a general overview of what we're going to talk about today, I know many of you are familiar with this study already, but we're going to review the Adverse Childhood Experience Study briefly and talk about some subtle nuances of the study that I think are important in terms of understanding and applying it to your work. We'll talk about a translation of that study that we did in Philadelphia. And then I'll close by talking to you about some evidence-based approaches to addressing trauma and promoting resilience amongst children and families. So you guys already know this was taken from the CDC website. Since 1999, we've seen an increase in the opioid epidemic.
Since 1999, nearly 500,000 people have died from opioid overdoses. More than 130 people die every day from the opioid epidemic. This slide shows you the 3 waves of the epidemic, first starting with commonly prescribed opioids, then changing to heroin overdoses, and then finally in this final wave here in 2015 and beyond, we've seen a change towards synthetic opioids. This is taken from the CDC website as well. And thinking about addressing this, these are some of the key factors or approaches. Monitoring trends to better understand and respond, advancing the research in terms of what works and analyzing data in terms of what works to actually help to curb this crisis, building state and local and tribal capacity by equipping states with resources and improving data collection, supporting healthcare providers as they prescribe opioid medications, partnering with public safety officials and community organizations to including law enforcement to address this growing problem, and then increasing public awareness. The reason why I listed these is because key to all of these approaches is understanding the root cause of the crisis and the epidemic. And I want to pose to you guys today that trauma is one of the main root causes of this epidemic. I hope so. That's why you guys invited me out here, right? So this is taken from a study published back in 2012. It looked at the association between the experience of trauma and the prevalence of an opioid addiction by different types of trauma amongst a sample of more than 600 individuals. What they found was that 97% of those participants had experienced some kind of trauma. More than 50% had experienced a life-threatening event or had been attacked or had seen some sort of severe injury or witnessed to death. 80% had simply had a close relative, something bad happened to a close relative. And important for us today, more than 30% had been hit or injured as a child growing up. Now, when you think about PTSD, the lifetime prevalence of PTSD amongst individuals who have substance using problems is 26 to 52%, highlighting the important role that trauma is playing in the development of this opioid epidemic. Now, important for us, we're going to talk about one particular type of trauma, early life trauma, or adverse childhood experiences. Now, adverse childhood experiences impacts the health and well-being of kids across their life course. If you were a mom who had been abused or neglected growing up, your child is at increased risk for fetal death. You take that mom's children, and if they have their own experiences of trauma, they're at an increased risk for things like cognitive impairment, behavioral problems, or developmental delay. Now let's take that child and translate them into adolescence, where they're at increased risk for things like mental health problems, but then their problems move out of what we traditionally associate with health and healthcare in terms of poor academic achievement and even involvement in the juvenile justice system, and unfortunately, later the criminal justice system. Well, looking to the far right hand side of that slide, what the adverse childhood experience study showed us is that those same individuals as adults are at an increased risk for an array of poor health outcomes, starting again with mental health problems, but also physical health problems, disability, and early mortality. Now, I want to remind you that one of those adverse childhood experience studies showed that individuals who report exposure to 6 or more of these experiences growing up, that their life expectancy can decrease by as many as 20 years. Now, this slide shows you how we think adverse childhood experiences gets under the skin, and it leads to disease and disability and early mortality. Now, adverse childhood experiences, particularly if they occur during sensitive periods of development. Now, what do you mean by that, Dr. Wade? As a pediatrician, you think about this as being between the ages of 0 and 6 years of age, when kids are undergoing periods of rapid brain development. And as a result, the brain is more susceptible to stressful and traumatic events. If kids experience trauma during this time period, they're at increased risk for things like social, emotional, and cognitive impairment. Now, if you look at the top-hand portion of our slide, that increases the likelihood that they will adopt what we call health risk behaviors. So things like smoking, drinking, substance use as a way of coping with ongoing stressors or even stressors that they had growing up. And then you can see how that directly translates into the disease and disability that we talked about before, and how that impairment in their developmental skills and cognitive impairment can translate into the social problems that have been associated with adverse childhood experiences. Now get this, folks. The same time that we've been reviewing this work on adverse childhood experiences, a parallel body of work in basic science has shown changes in one's stress response system as a result of exposure, particularly to early life stress and trauma. You guys know this, it's your fight or flight system. In medicine, we call it your hypothalamic pituitary axis system. We always have to have a fancy way of saying something, right? But this is the system that produces hormones like cortisol in response to a stressful situation. Running to catch an airplane because you have a talk at 9 a.m. tomorrow, waking up and having to give that talk even though you're dead tired, right? In response to stress, right? And that's adaptive. It helps you to respond to that. But what we know is that system goes awry when you experience overwhelming stress and trauma early in life, leading to overproduction of these stress hormones, which then alters your immune cell functioning, and then underscores the changes, the adoption of those health risk behaviors, and magnifies one's risk for poor health outcomes. Now, as I said before, the landmark study, at least for us in pediatrics and healthcare, is called the Adverse Childhood Experience Study. It was a study, for those who don't know, that was conducted in the mid to late 1990s by researchers from the Centers for Disease Control and Prevention out in Atlanta, Georgia, and Kaiser Permanente in San Diego, California. It was an elegant study. They recruited more than 17,000 of the policyholders in San Diego. And in essence, they asked them 10 questions, which I list on the left-hand side of your slide. I've grouped them into 3 major domains. And so what they said was, prior to age 18, were you abused, either emotionally, physically, or sexually? Looking down at the bottom of the chart, did you experience neglect prior to age 18, either emotional or physical? Or were you exposed to some sort of household stressor, substance abuse in the home, a care provider with mental illness, domestic violence, an incarcerated care provider, or your parents divorced or separation? Now remember, guys, in essence, 10 total questions from which the researchers created what they called an adverse childhood experience score, ranging between 0, if you were exposed to none of these experiences, and 10, if you reported all. What the researchers then looked at was the association between just that score and the respondent's risk for an array of different health outcomes. So this slide shows you the relationship between the respondent's adverse childhood experience score and their risk for cardiovascular disease. You can see on the bottom axis their ACE score, ranging between 0 and 8, and their odds ratio on the left-hand side are risk for cardiovascular disease, things like strokes, heart attacks, and high blood pressure. What I want to show you guys here is simple. At every incremental increase in the respondent's risk in a respondent's adverse childhood experience score, you see an incremental increase in their risk for cardiovascular disease. That's a key point, guys. No adverse childhood experience score is protected. In pediatrics, we say in terms of lead exposure, there's no safe dose of lead. You shouldn't have lead in your body. What this is saying here, that there's no safe dose of adverse childhood experiences. You shouldn't have it in your life. But what the researchers then found was this same graded relationship for an array of different health outcomes. Starting with, as we talked about before, health risk behaviors, smoking, drinking, substance abuse, and high-risk sexual behavior. Moving on to mental health conditions such as depression, anxiety, PTSD, and suicidality. And then finishing with physical health conditions, cardiovascular disease, emphysema, cancers, autoimmune disorders, liver dysfunction, sexually transmitted infections, and the list goes on. Now I've highlighted in red some of the leading causes of death and disability in our country. Now, there's often a conversation, in the last 15 to 20 years about how can we bend the healthcare cost curve, particularly for our senior citizens. How can we improve the health of someone who's 60 or 70 or 80 years of age? Now, ladies and gentlemen, if you believe that the Adverse Childhood Experience Study is correct, is accurate, what it is saying to you is that if you want to improve the health of a 60 or 70-year-old, you should start when they're 2 and 3 and 4 and 5 in terms of improving the social conditions in which they grew up in. Now, there's a certain group of people in the Adverse Childhood Experience Study who are at increased risk for poor health outcomes. These are individuals, and you'll hear me say this over and over again, who have experienced significant childhood adversity. They report exposure to 2, 3, 4 or more of these traumatic experiences. These are simply individuals who, in every aspect of their life, found no place that was safe and were exposed to trauma in almost every way that you possibly could be. These individuals displayed a 4 to 12-fold increased risk for the health risk behaviors that we're talking about. So when we're thinking about substance abuse, these are the highest risk individuals to actually develop substance abuse problems. And nearly a 2-fold increased risk for many of the diseases we discussed as well. Now, when thinking about ACEs, there's been this call across all disciplines to start asking about ACEs, to screen for ACEs. You'll hear me use the word to assess ACEs. When we think about this work, we largely constrain our focus to what we consider to be the most caustic and toxic experiences, right? Things like sexual abuse or physical abuse. What I'm going to tell you today and what I'm going to challenge you on, if you identify a person with 1 ACE, they're likely to have 2, 3, or 4 more ACEs. Why is that important? It's because the individuals who report exposure to significant adversity, to 3, 4 or more ACEs, those are the individuals who are most likely to have substance abuse problems. Here, let's take this slide. Right, this is from the Adverse Childhood Experience Study. It shows you that each individual ACEs that were assessed as part of the study, and then the prevalence of those individuals who had 0, 1, 2, 3, 4 or more ACEs, right? And so let's take those individuals who reported emotionally abused. Well, more than 60% of the individuals who said, I was emotionally abused growing up, had an ACE score of 4 or more. What about physical neglect? 50% of the individuals who said, I experienced physical neglect growing up had an ACE score of 4 or more. And then finally, domestic violence. We see nearly 50% of those individuals who had violence within their home had an ACE score of 4 or more. Why is this important, Dr. Wade? Well, if you identify 1 ACE, you need to be asking about more. But we cannot constrain our focus to what we consider to be the most toxic ACEs. We have to ask about them all. ACEs, as was alluded to before, also have an intergenerational effect, irregardless of the child's exposure to ACEs. This study shows you the association between a mom's exposure to adversity as a child, whether or not she was maltreated as a child, and her child's risk for maltreatment. What I want you to see here is on the x-axis, on the bottom axis, you see the severity of her exposure to childhood abuse, and then her odds ratio or risk, her child's risk for having emotional problems. All I want to show you here is you see that same dose-response relationship. When the researchers looked at what were some of the factors that mediated this relationship, what were the mechanisms through which the mom's adversity affected the child, you see some socioeconomic factors and some ACEs, right? So the moms are more likely to be harsh or to use permissive parenting practices. There's more likely to be low attachment between the mom and the child. There are also socioeconomic factors like low income and education, but you also see ACEs, depression, substance abuse problems, domestic violence, maltreatment, and even just a chaotic household. What I want you to know here is that there's an abundance of work showing you there are actually molecular mechanisms through which mom's experience of adversity, we won't get into that today, hopefully you guys will ask me in the Q&A session, through which mom's experience of adversity transmits to her child and increases her child's risk for poor health problems. All right, we good? All right. Now we're going to transition a little bit. I'm going to talk to you briefly about our adoption of the Adverse Childhood Experience Study in Philadelphia. Now, I pray that your first question is, why the heck would you do that, Dr. Wade? It is a sobering enough study already. Why would you repeat that study? So guys, I knew you guys were going to ask me that question, so I put this slide up, okay? So Dr. Wade, what does this slide show you? This slide shows you the demographics in the middle column from the ACE study. And then on the far right-hand side, the demographics from Philadelphia taken from a recent census. All right, this is my first time giving a presentation in this mask, and it just keeps fogging up. So I'm gonna need some help reading the slide. I got most of it memorized. I'm gonna need some help reading the slide. So I need you guys to call it out for me in terms of the differences. So in Philadelphia, in comparison to the Average Childhood Experience Study, we are younger. Come on, give me something general. We are younger. We are more, thank you, we're more diverse. We are less likely to graduate from, and then as a result, less likely to graduate from, and then more likely to live in, what the heck does poverty have to do with it, Dr. Wade? Well, unfortunately, those conditions, those 10 toxic experiences that were described earlier on are more likely to occur in economically distressed settings. But we know that those 10 experiences don't capture the broad array of stressful and challenging things that happen to kids growing up that impact their health and well-being. I didn't say anything about community violence. I didn't say anything about racism. I did not say anything about bullying. All individually have been shown to impact the health and well-being of kids, but they weren't included in the study. Why is that important? It's because, as I said before, the number matters. What your ACE score is matters. And if our ACE score is constrained to things that mostly happen in the home, and we don't capture those things that happen in the community that are stressful for kids and impactful for kids, then we may be missing kids who have had toxic experiences, are at increased risk for poor outcomes, and then we're unable to intervene. That's the primary reason why we conducted this study. Here's some data to support that. This study was done by a colleague of mine, David Finkelhor, out of the University of New Hampshire, and his group. It's an elegant and simple study. They surveyed 2,000 young people and asked them the original ACE questions that are outlined on the left-hand side of your slide. And then they identified additional adversities that they asked them as well. And they looked at the association between each individual experience and the young person's likelihood for having PTSD symptoms. Basically, whether or not the kid had PTSD or not, right? They did that individually and then mixed them all together. So initially, when they looked at all those original the original ACE questions, ACE items together, individually, they found that each one was strongly associated with high levels of PTSD. So if the young person reported it, they were more likely to have PTSD. And then when they asked the additional adversities, they found the same thing. But when they threw them all into the same pot, in the same equation, and looked at them together, the additional adversities actually remained strongly associated with PTSD symptoms. 2 of the original ACEs actually fell out: incarcerated household member and parental separation or divorce. Now, I won't be able to talk about this today, but I'm hoping that someone in the Q&A session, hint, will ask me, well, Dr. Wade, why do you think parental separation or divorce fell out? Okay? All right. Now, this is from that same study. It's just looking at the prevalent, essentially are neighborhood level events, events that occur outside of the home, right? And so the 5 we identified were witnessing violence growing up, living in unsafe neighborhoods, experiencing racism, living in foster care, and experiencing bullying. Now, when we looked at the prevalence of just the original ACEs in Philadelphia, as I told you before, we found that they were higher amongst our population. Many of them were. So things like emotional abuse and physical abuse were nearly 1/3 of our respondents reported exposure to that. But things like substance abuse in the home. We did see a lower prevalence of sexual abuse. But when we talked to our child abuse experts, they said that that doesn't necessarily reflect something that we were doing in Philadelphia. It probably reflects decreasing trends across the country. Now, more than 40% of our respondents said this: I saw someone being hit, bit, beaten, kicked, stabbed, or shot growing up. More than 1/3 said, I just felt discriminated against growing up. And more than 1/4 said, I just lived in a neighborhood that wasn't safe. Now, when we looked at the prevalence of the ACEs and looked at it by ACE score, remember in the initial ACE score, about 12.5% of the respondents said they had 4 or more ACEs, or were reported to have 4 or more ACEs. In our study, 40% of the respondents had 4 or more ACEs. I'm doing a little bit of a sleight of hands, right? I knew you guys were going to catch me on this. So this represents the total ACEs, right? Our total ACE score, including the expanded and the conventional ACEs, which ranges between 0 and 14. So you're going to be more likely to report 4 or more ACEs just because there's more ACEs to report. I knew you guys were going to catch me on that. So I put together this slide. This slide just shows you, this looks at the original ACEs. Now blue is from the Kaiser CDC study. Red is from the Philadelphia ACE study. On the left-hand side, you see the prevalence of individuals who report 1 or more of the family level ACEs. On the right side, you see the prevalence of individuals who report 1 or more of the 4 or more, of the family level ACEs. Guys, what do you see? In terms of 1 or more of the original ACEs, there's actually not much of a difference between the Kaiser CDC study and the Philadelphia ACE study. Where you do see a difference, and this was a statistically significant difference, is in significant adversity. The percentage of individuals who report 4 or more of these events. Remember, in the Kaiser CDC study, it was 12.5%. For us in Philadelphia, it was 20%. Why is that significant, Roy? You guys okay if I call myself Roy? Well, this is why. There's about 1.5 million people in Philadelphia right now, maybe a scooch above that. If we did a good job in creating a representative sample and surveying that population, what you can say with pretty good accuracy is that there's some 300,000 people in the city right now with an ACE score of 4 or more. Ladies and gentlemen, that's sobering. Right? Because those are the people who are at the markedly increased risk for poor health outcomes. Now, what that bears in mind is, well, what are you doing with this information? Knowing that, how are you using that to target and tailor services to the people who are most likely to have substance abuse problems or even later have physical health problems? And I think we're still grappling with that issue right now, but I'm going to give you an example later on about how I think you can do it. Okay? All right. So, a lot of people call me the poverty doctor. There's actually this article about me in the Philadelphia Inquirer. I'm like the poverty doctor. And I don't mind it. I take it, right? Part of what brought me to this work is something around poverty and how can we at least decrease the level of poverty. But many of the skeptics of this work say, well, it's really just about poverty, Roy, right? The same people who report high levels of family level stress are the same people who are going to report high levels of community level stress, right? You don't have to be that detailed. You can ask one or the other. It doesn't really matter. Well, this Venn diagram was truly created to get at just that point. What you see here is on the left-hand side of your slide, you see the prevalence of individuals who report at least one of those original ACEs. Remember, we termed that conventional ACEs just to trip you guys up, okay? And the right slide shows you the prevalence of individuals who reported at least one of those expanded ACEs, those community level ACEs, right? And you see the congruence or the confluence in the middle, right? And for 50% of the population, they're right. They say, yeah, things are stressful in my home, but things are also stressful in my community. But look at that right-hand circle. 14% of the respondents said this. Things are actually growing up. Things are actually okay in my home. It's actually in my community where they were stressful. That's important because if you constrained your assessment to just those family level events, you miss that 14% of the population who are likely to have or at increased risk for having poor health outcomes. Well, you might say, you haven't shown me that you can take these expanded level events and put them to a composite measure and associate them with poor health outcomes across the life course. Again, I knew you guys were so astute that I had to come with my A game. So I put together the slides just for you guys, okay? So this slide shows you the association between ACEs in the Philadelphia study and risk for smoking. The far left-hand bar graphs are just for the original ACEs. The middle are just for the expanded ACEs, and the right are for the total ACEs, the composite score, including both the conventional and the expanded. We group them into more categorical variables. So the blue represents 0, the red represents 1 to 4 ACEs, and the green represents 4 or more. All right, and this is just the odds ratio for smoking on the left-hand slide. What I want you to see is you see the same dose-response relationship. We also saw that for substance abuse problems as well. So you use substance abuse problems, right? So the same format here, right? Conventional ACEs, expanded ACEs, total ACEs, and risk for substance abuse problems on the y-axis, and group them into the same categorical variables, right? You're seeing that same dose-response relationship. Where the relationship started to fall off a bit was with physical health outcomes, right? So this is showing you the association between ACE scores in the Philadelphia study and risk for cardiovascular disease. And so you can see that the conventional ACEs, or those original ACEs, has that same dose-response relationship. You lose that dose-response relationship with the expanded ACEs, and it comes back for the total ACEs. But this sort of makes sense, right? Let's think about it. I started off this talk by telling you that kids are most susceptible to these experiences when? Between the ages of 0 and 6. They're undergoing rapid periods of brain development, right? Well, what's most likely to be occurring, or what ACEs are they most likely to be exposed to between the ages of 0 and 6? Yeah, those family level events, right? You know, 3-year-old and 4-year-old, they do get outside of the home, right? But they're not interacting with their social environment, right? They're interacting mostly with their parents and their siblings, right? Or the caregivers and their siblings. So just by default, right? Because of their exposure, those conventional ACEs are more likely to be impactful. But also there's something else, right? Is that the average age for the Alda-Felitti study was in the mid to upper 60s. The average age for in our Philadelphia study was in the mid to upper 50s, okay? And these physical health outcomes, many of them are age-related diseases and disabilities. And so our population might not have been old enough to really start to see that effect, right? What this speaks to, right, is the importance of the family relationships. But I don't want to be dismissive of these expanded ACEs as well, at least as they pertain to physical health outcomes. And here's why. Because we know just like kids don't grow up in a bubble, parents don't parent in a bubble, right? So this slide shows you the association between those neighborhood level ACEs, those family level ACEs, and a child's experience of toxic stress, which is what we're talking about when an individual has experienced significant adversity. Now, I know that toxic stress is something internal, right? I drew it external to the child, but it's something that internal that the child feels. But for the purposes of this slide, I externalized it so that you could understand it, all right? So what this slide suggests to you, right, is that there's a direct effect of these family level events on a child's toxic stress, a parent's ability to be nurturing and supportive. Also, these neighborhood level events can cause toxic stress as well, but they also influence the parent, right? Just like a parent, an African-American parent who's experiencing racism. It's going to be harder for them to come home and be nurturing and supportive for their kid. And thus, it's going to be more likely that that kid is exposed to toxic stress. Well, there's a study to support just this finding. It was conducted out of my home state, Georgia, right in Atlanta, amongst African-American women using their firstborn child. It's an elegant study again, and here's what it did. It asked the moms about their experience of racial discrimination currently. It assessed for their level of stress via life events, struggling with their job or money problems. They were administered a test looking at the mom's level of psychological functioning, whether she was anxious or depressed. And it looked at the quality of the relationship between the mom and that firstborn child. And so they identified 3 groups based on this study. The first group of moms said, actually, I'm not experiencing any racial discrimination. And when they looked at her life events, they said, no, I have low levels of stress in terms of my life as well. And as you might imagine, those moms had low levels of depression and anxiety, and the quality of their relationship with that firstborn child was actually pretty strong. The second group of moms said, again, I'm not experiencing much in terms of racial discrimination, but life is a little tough. I'm having to struggle with money or just lost my job. And as you might imagine, they had a higher level of depression and anxiety, and the quality of that relationship with their firstborn child was diminished. Now, the third group of moms said, yes, I perceive and I feel discriminated against. And at the same level of life event stress, they had twice as much in terms of depression and anxiety, and the quality of the relationship with that firstborn child was twice diminished in comparison with the other group, with the middle group, highlighting the role that these neighborhood factors can play indirectly in increasing toxic stress for kids. All right. Now, in thinking about our group in Philadelphia, we found certain populations or groups of people who were more likely to report exposure to significant adversity, 4 or more adverse childhood experiences growing up. Males were more likely to report 4 more ACEs than females. Blacks were more likely to report 4 more ACEs than whites. And people living in significant poverty as an adult were more likely to report 4 more ACEs. Well, let's tease this out a little bit, okay? Let's look at the socioeconomic piece first, all right? So we all know, and we talked about this as part of this talk, but even before this talk, ACEs increases the likelihood that you're gonna live in poverty as an adult. Now, ACEs and socioeconomic status of poverty have their own separate influences on health outcomes. Now, what if they actually work synergistically to worsen outcomes for individuals? What if people with high ACE scores who live in poverty are more likely to have poor outcomes? We actually found that to be the case. So these next 3 slides, we have to be careful as you follow me along, okay? They're only done amongst the individuals who report 4 or more ACEs. All right, so we cut the population down to just that group. And we broke them down by whether or not they were high SES, no poverty, in blue, and then whether or not they were low SES, they lived in poverty, red. And on the left-hand side, you're looking at the conventional ACEs. On the right-hand side, you're looking at the expanded ACEs. And we're looking at their risk for sexually transmitted infections. All I want to show you here is that looking at the red, if you live in poverty and you have 4 more ACEs, you have a dramatically increased risk for sexually transmitted infections. Same thing for substance abuse problems, guys. Again, the same format, blue, high SES, red, low SES, conventional ACEs here, expanded ACEs here, risk for substance abuse problems. If you live in poverty and you have 4 more ACEs, you're more likely to have substance abuse problems. And then also the same thing for mental health conditions as well. All right, you guys want to get even sobering? I'm going to go ahead and answer one of the Q&A questions right now. The reason I came to this work was because when I was a medical student, I trained at Dartmouth College in New Hampshire. Our instructors introduced us to the concept of health disparities. This idea that based on your background, either your race or your socioeconomic background, or your sexual preference, or even your gender, right, you can experience differences or disparities in health outcomes, a higher level of health or poor health outcomes, right? And we asked them, I remember raising my hand and saying, well, what's the cause of these differences? Can anybody guess one of the first things they said? Genetics. As if there's a gene that makes African Americans more likely to struggle in school, to be incarcerated, to have heart problems, right? That's a pretty powerful gene. And that's most of that's been debunked, right? Then they pointed to behavior, right? There's something culturally about African Americans. They eat too much greasy food, they don't exercise enough, list goes on, right? It only came after a few years when I went to Harvard and started studying this in more detail that I was exposed to the concept of social determinants of health, right? That the environment in which you live can actually put you at higher risk for an array of different health outcomes. But even in that setting, not one person mentioned the idea or concept of trauma exposure. Now, I want you guys to hear me and hear me very clearly, all right? Dr. Wade is not saying that Black and brown people are innately more likely to beat up on their kids than other people. But these are groups of people in our society who, since they came to this country, or in the case of Native Americans, were booted off of their land in this country, have experienced historical inequity that has relegated large swaths of these groups to economic distress. More importantly, has relegated these groups to intergenerational poverty. And it's poverty that creates the conditions, the stressful conditions upon which ACEs are more likely to occur. And so what brought me to this work was just that focus. How has historical inequity led to increases in racial and ethnic minorities living in poverty and increasing the likelihood they're exposed to trauma as children? And how does that explain differences in health outcomes? Well, this is right up you guys' alley here, because we identified 4 Black-white differences in health outcomes in our Philadelphia study. Sexually transmitted infections, where 21% of the Black population reported sexually transmitted infections and compared to 70% of the white. Substance abuse problems, 16% to 7%, diabetes and obesity. Specifically, we looked at substance abuse problems. What explains the Black-white difference in substance abuse problems? The pie chart on your right-hand side shows you. We'll just cut to the chase. Conventional ACEs are outlined in blue, expanded ACEs are outlined in red. What I'm telling you is 10% of the Black-white difference in substance abuse problems can be explained by differential exposure to conventional ACEs in our Philadelphia study. 20%, 22% of the Black-white difference in substance abuse problems in our study could be explained by differential exposure to expanded ACEs. Nearly 33% of the Black-white difference in substance abuse problems can be explained by differential exposure to childhood trauma. Why does that matter, Dr. Wade? Sorry, Roy. Why does that matter? Who cares? Here's why you care. Right now, the NIH and foundation after foundation after foundation, even right now in reference to COVID, is trying to understand what are the pathways through which health disparities occur. Why is it that African Americans are experiencing COVID at higher rates? Why is it that African Americans have higher rates of cardiovascular disease? And there are many reasons why, guys. In terms of COVID, being more likely to be essential workers, living in multi-generational homes. This goes on, right? And what they're challenging researchers and interventionists to do is to develop programs and interventions to disrupt these disparities. My argument to you guys here today is if that intervention doesn't include someplace in their conceptual model, it doesn't have to tackle trauma directly, but if it doesn't account for historical inequity and the experience of trauma and the differential exposure to trauma, that intervention is flawed. All right, now, I want to switch topics really quickly. I'm going to have to speed through this because I've been doing too much theatrics here. But I feel like the point needs to be made. Because right now, there's a group of people who are going around saying that we need to constrain our definition of ACEs to those 10 experiences that were included in the Onda study. I'm not totally sure why, but it's actually gaining traction. Right? And I think that that's flawed because do you guys know how Onda and Politi came up with those 10 ACEs? They sat around a table, they read a couple of articles, and they said, these are the things that are most impactful for kids. There's no empiric evaluation of it. Dr. Onda and Dr. Politi will tell you that themselves, right? These are the ones that just seem to make the most sense from their reading of the literature. I think it's particularly important to understand the role of racial discrimination as an ACE because of its pervasive effect on kids. It's within our media, it's within our culture. If you are a minority in this country, it is infused almost within every interaction that you have. You can't escape it. It's almost like you're being bullied, right, on a higher and more intense level by everybody in your society. So in terms of racial discrimination, it's a form of social inequity that includes experiences resulting from legal and non-legal systems of discrimination. These systems of discrimination create dominant and secondary social groups that differ in levels of power and access to goods and services. This conceptual model might look familiar. We'll show you in particular how we think racial discrimination gets under the skin and leads to lifelong health outcomes. Again, exposure to racial discrimination here leads to a decreased sense of self-efficacy. What's self-efficacy, Dr. Wade? Your ability to say, I can advocate for myself, that I can do this on my own. Your sense of your own agency and purpose in life, right? And what we know is that there are two types of racial discrimination that we are really important. That personal, direct, or vicarious experience, the interpersonal experience, right? But more commonly, what kids are experiencing as they grow up is institutionalized. The practices, the policies, the way we behave, the different stereotypes in which they're exposed to in the media and in our society. The subtle microaggressions that they see on their TV, and they see in the news on a daily basis that say, you're not as worthy, you're not as important, you're less than. That leads to decreased self-efficacy, which leads to a likelihood, if you look across the top end portion of your slide, an increased likelihood that you experience psychological distress. I can't do anything for myself. I just can't win. And studies have shown that increases the likelihood that you adopt risk-taking behaviors, violent behaviors, and leads to chronic illness as well. At the same time, a parallel body of work has shown changes in your stress response system and your immune cell functioning, but then underscores those changes in behavior and magnifies one's risk, leading to increased likelihood for things like susceptibility to infections, and we think even premature births. Now, in terms of the associations, there have been numerous studies that have shown higher levels of depression amongst Black youth have been associated with group-level differences in perceived in depression. It explains the Black-white differences in depression. Higher levels of violent behavior amongst Black males. It's been thought to be associated with decreased levels of moral reasoning, empathy, and their perceptions of justice, that this world is just not a fair place for me. Or also things like increased inflammatory markers, highlighting the changes in your immune cell functioning, increased rates of preterm birth that we talked about before, so have been associated with lower self-esteem amongst African-American women, and even nearly a threefold increased risk for coronary heart disease. Now, that, as I highlighted before, doesn't take into account this historical inequity, right? That comes through the application of institutionalized racist practices, things like discriminatory housing, poor resources for funding of schools, and limited access to quality jobs in which minorities live in, which then relegates them to poverty, which then magnifies their risk for exposure to adversity. All right. Have I significantly depressed everybody in the room? Well, I'm going to leave you with hope. All right. We're going to talk about ways to address toxic stress, right? Now, before I do this, as I go through these practices, I see three key areas, right? Understanding adversity, understanding this information helps you to change your practice on the interpersonal level as you engage with your clients and your patients. It also helps you as an organization to institute practices or interventions, right, that mitigate or disrupt the impact of trauma. And then there's a systems effect, right, that we can have that I'm going to close with, right, and talk about what we can do about today. All right? So as we think about these, think about how each one of them fits into one of those buckets. And some can go across, right, but some are clearly in one domain more so than others. All right, but to do that, we have to sort of redefine adversity, okay? All right, and so this is taken from Harvard, the Center on the Developing Child. This is their definition of stress, right? So there are three types of stress. Positive stress, which is brief increases in the heart rate, mild elevations in one's stress hormone levels, right? I'm a pediatrician, so just to give you an example of this, as part of my practice, I administer vaccinations or give vaccinations to kids. But I'm a little bit, sneaky in my practice, right? What I'll do is I'll say, oh, yeah, you got to get your flu shot today. And, and I'll tell, in the room, I'll say, the nurse is going to come in and give it. The parents ask, well, you going to give it? No, the nurse is going to give it, right? And then I'll walk out and I'll order it, right? And then the nurse will say, oh, well, Dr. Wade, can't you go back in there and give, you got to hand them out the paperwork. Can't you go back in there and give the shots? No, I got to go see my other patient, right? And then I'll wait, right? The nurse goes and he or she draws up the vaccine. They go into the room, and I go into the nurse's room and I get some stickers or a lollipop and I'll wait, right? And when I hear that crying, I pop in and I say, here you go, right? And I'm the good guy, right? That's positive stress, right? Now, tolerable stress can be something serious, like the death of a loved one in your family. But the key is that it occurs in the presence of a supportive relationship. The key here, guys, is when I talk about someone who has experienced significant adversity growing up, but I'm talking about someone who has experienced toxic stress. Prolonged activation of their stress response system occurring in the absence of a supportive adult relationship. What happens is those individuals enter a cycle of toxic stress. Where they're exposed to toxic conditions, it changes their stress response system, puts them in a chronic fight or flight state. It leads to changes in their brain architecture. Studies have shown that too much cortisol actually impacts the development of a young child's brain. And it makes them hyper responsive to stressful situations. You guys have seen this. It's that kid who walks into your program. Right? And you say, don't lean back in your chair. And suddenly they fly off the wall, with explicative after explicative after explicative after explicative. Ladies and gentlemen, understanding trauma recognizes that they are not yelling at you. They are not saying those curse words at you. They are cursing at their lives. And that increases the likelihood that they're exposed to further toxic conditions. And the cycle goes on and on and on. And people ask me, well, what, Dr. Wade, you're this pediatrician, you study this work. What disrupts this cycle? We already know it, ladies and gentlemen. Uh-oh, that was supposed to be like my, moment. Jesus, come on. Right? a relationship with a consistent, caring adult. Study after study after study. I would guess that there are people right here in this room today, there are people on this call with 4 or more ACEs who have done quite well with their lives. And if you sat them down and you asked them, what made the difference for you? What would they say, ladies and gentlemen? Some adult sat down with me and cared and listened. Study after study after study after study supports just that. You want an evidence-based approach to disrupting the impact of trauma? Link a kid who's been traumatized with an adult who cares. Here's the key, ladies and gentlemen. I did not say parent. Now, I'm not trying to disrupt. I understand the primacy of a relationship between a mom and a dad and their kid, how important that is. But this fact alone, this research alone is encouraging to me. It means that any adult who cares can disrupt the cycle of trauma in a kid's life. Can take a kid with an ACE score of 4 or more and change their lives. He's a teacher, a clergy, a pediatrician, a coach. All you got to do is care. But when we look across our society and we look at the programs that do this, the Boys and Girls Clubs, the YMCAs, they're underfunded and they're understaffed. Ladies and gentlemen, where are our priorities? We care about kids. We'll support adults who care about kids. Now, as you think about approaches, there are ACE-informed approaches. And this comes from a pediatric article. All right, and so this is one of those organizational practices. There's assessment, we talked about before. There's providing anticipatory guidance. So as a pediatrician, I can sit down with the family and I can help them to understand how the trauma they've experienced is impacting their health and well-being and ways they can go about promoting positive parenting and keeping their kids safe. Promoting awareness amongst our practitioners and within our communities. Referral to community-based services, trauma-informed services. Training for providers on how to ask and talk to families about trauma and how to respond. And then guidance in terms of decision-making. This is taken from one of my colleagues, Joel Fine at the CHOP, and it talks about the importance of ACEs knowing, right? So this idea, like I'm trying to move people away from this term of screening, right? Why, Dr. Wade? Why is screening so bad? Because in pediatrics, I don't know about and you guys feel, but in pediatrics, when we screen for something, there's this sense that I have to do something immediately about it, right? So if I screen for ear infections, then I better have amoxicillin on hand to treat it, right? Well, I'm arguing here that their role in assessing, I like to use the word assessing ACEs, is that it actually helps us to change. Actually, it does more for us in actually changing our practice and our relationship to our patients. And here's how. So my colleague calls it ACEs knowing. It helps us to build trauma-informed approaches so we can adjust our procedures, right, to decrease patient stress, right? We can anticipate needs of patients, right? And so right now, our well child visits have been constrained to 15-minute visits, right? Even for our adolescents, right? Which we all know is minimum an hour, right? I mean, getting an adolescent just to say what school they go to takes them like 10 minutes, right? Right? But in a morning huddle, I can sit down and I can look at my list and I can say, well, the Joneses are going to be here at 3 o'clock, right? And so I know that the mom has an ACE score of 7. I know that the kiddo has an ACE score of 4. And that's not going to be a 15-minute office visit, right? And so what that allows me to do is say, hey, John, can you take my 3:30 and I can ask Sue, can you take my 3:15? Because I know I'm going to need some extra time to work with the Joneses to help them through some of the issues that they're going through. It also lets me to tap my social worker shoulder and say, the Joneses are coming in at 3, right? can you be ready just to come in? Because we might need to identify some more supports for them to help them with some of their needs. Right? It helps you to plan your day better, right? Here's the other kicker. I am not a trauma therapist. I have immense respect for what trauma therapists do. But just by value of having this longitudinal relationship with the family, this trusting relationship with the family, the trust that they have in me actually helps them when I talk to them about their adverse childhood experiences. Just me acknowledging that these traumatic and stressful things have occurred to them, right, is in itself therapeutic. But furthermore, I get to say this when it's identified. I'm sorry that these experiences happened to you. They're not your fault. You didn't deserve them. You didn't bring them on yourself. We know that these experiences have been associated with poor outcomes, and these things can happen, but there are ways to mitigate or to break the cycle of these experiences. And you don't have to internalize these experiences and make them your own. You can externalize them and say, this is with somebody else. And you can rewrite your future moving forward. I can be the start of that process. I might not be skilled enough to take them through it. I don't have the training to take them through it. But just by being that trusted pediatrician, I start the process. And then helping patients build capacity for emotional control, learning what their triggers are, right? You've been abused, right? So what triggers your emotions? What's likely to have you get into that fight or flight state? Identifying them and then using mindfulness practices, right, to help control their emotions within those settings. Avoiding situations in which those triggers might occur. A lot of times, what I see in my parents, when they're not using positive parent approaches, is that their child does some behavior that triggers something in them. It triggers them and moves them into a fight or flight state. And so just by talking to them about, hey, I noticed that when your child did this, you started to get really upset. What was that all about? I'm not a trauma therapist, right? But I'm helping them to identify like what within their child's behavior is actually makes it harder for them to be a strong parent. And then to develop approaches that they can use to actually calm themselves down in that situation, count to 10, right? Think of happy thoughts, and then re-engage in that situation and be the positive parent that they already are. All right, I'm heading down towards the end, guys. And then these are strategies or approaches to address toxic stress, right? So a lot of our efforts, right, are surrounding parent support. Right? How do we support parents and help parents be the positive parents that they already are, right? Home visiting programs or parent-child interaction therapy. For kids with depression or anxiety, trauma-focused cognitive behavioral therapy has actually become the standard of practice. Mindfulness training, and even things like non-cognitive skills or promoting non-cognitive skills. So there's been an abundance of research looking at things like how can you take an individual who has been abused and improve their cognitive skills. And the research suggests that you can't really move the needle. But what you can help that individual do is to show up for class on time, sit in the front row, raise their hand when they have questions, engage peer groups in their learning. And what research suggests is that is actually more effective than taking a teenager, right, who has been traumatized and helping them be successful in school than trying to improve their cognitive skills. All right, in terms of mindfulness, here, this study shows you how mindfulness moderates the negative effect of trauma. This was actually taken or done by a colleague of mine amongst early Head Start practitioners. What they found was a significant number of early Head Start practitioners had high ACE scores. And they looked at the use of mindfulness approaches amongst these practitioners and saw that those people who were more likely to adopt mindfulness approaches had higher health outcomes, had better health outcomes, had better mental health, had fewer health risk behaviors, and reported a higher quality of life, even for the same adverse childhood experience scores. And this is a study conducted by a researcher out of Maryland. It's called the SEEK model, right? And it was a randomized controlled trial amongst 11 practices in the Baltimore area in Maryland. What they did was they randomized these practices to two approaches. One, used the SEEK approach, where the providers were, as part of their routine well child care, screened for risk factors for ACEs or ACEs outright. And then as part of that practice, worked with a social worker to help families to connect to resources to address those risk factors. And then the other practice just use standard of care. You could screen, you could not screen, you could do whatever you wanted. They followed those families over a 12-month period, and at the end, they did a retrospective report, a review of the chart for any CPS referrals, for any Child Protective Service referrals. And then they administered the parent-child tactic scale to look at the use of harsh parenting amongst the participants. And this is what they found. In terms of CPS reports, you were 2 times more likely, almost 2 times more likely to have been reported to CPS if you were in the control group. If you were in a group where they didn't screen for ACEs or ACE risk factor, then they didn't connect you to services. And those individuals in the intervention group use a statistically significant less in terms of approaches, use of physical assault approaches or harsh parenting practices, than the control group. Now, this is some qualitative work that they did after it, and what they found was that the health professionals who were in this study, particularly those in the intervention group, said they actually felt pretty comfortable about screening for risk factors for ACEs. They saw a 25% increase in screening rates. And the practitioner said it didn't take them more time, and it all came at a cost of $5 a family. I'm telling you, an evidence-based approach in primary care to actually mitigating the impact of making it less likely that kids get exposed to trauma. Now, you would assume that the AAP has adopted this, and this is like standard of care, and every pediatric practice is using it. Anybody got his kid in the room? Are they using the SEEK model? Unfortunately not. All right. Now, I'm coming down the pipe. We're almost done. In Washington State, the researchers there and the policy leaders there, over a successive, over 3 separate years, mapped out the prevalence of ACEs across the county, across the state, and labeled high ACE populations, populations that had 3 or more ACEs by county. And they looked at those counties that had high ACEs and targeted home intervention services to those counties with high ACEs. And this is what they found. As you can see, what this graph shows you is by age group, the prevalence of individuals with 3 or more ACEs. You actually see the lowest prevalence amongst the individuals who are 65 and more. You see an increasing prevalence amongst successive generations, except in our target group. Our target group is in green, and these are individuals who are from the counties where home visiting services were targeted to their counties. What I want you to see here is that instead of seeing that curve go up in the 18 to 34 population, you're actually starting to see a bend. You're actually starting to see that go down. All right, and then to close, finally what I want to talk about is this importance of developing or promoting resilience amongst our populations, right? So as we talk about ACEs, one of the things we are really focused on is how do we actually help kids who have experienced trauma develop resilience to that trauma. And when we think about resilience, right, it's the ability of an individual to rebound, to recover from their adversity, and to return to their homeostatic state. Now, the key points are, it's the homeostatic state, and we've particularly focused on the lack of poor health, right? I want to argue that the lack of poor health is actually not as important as we think. It's important, but it doesn't necessarily represent resilience, because you can have high levels of resilience and still develop poor health, right? Just genetically speaking, right? And as we think about resilience, what we want to focus on is that resilience is actually a process through which an individual is exposed to adversity, perceives that adversity, but then looks at it and doesn't see it as an overwhelming condition, and uses the protective factors that are available to them to actually respond to their adversity to lead to a more positive outcome than we would have expected. What are key components of this, right? So it's a process. I talked about the presence of adversity or some exposure, and then the specific risk for poor outcomes, and the fact that the individuals have to utilize the protective factors to actually help to improve the outcome better than what we would have expected. Those protective factors can be personal, internal, or they can be environmental, within their family, or within their community. And they benefit the person's long-term functioning. What resilience is not, is the opposite of risk. It means that it's not that the person is not exposed to these adversities, and it doesn't have to have the absence of physical health symptoms. It's a trait, and it's not a trait. Why is that important, right? Because what we know about these protective factors, and we talk about what they are in a second, is that they can wax and wane over time. Protective factors can be physical health, right? I can exercise, I can get out, and I can run as a way of stress reducing. They're cognitive skills. You might be smart enough to know ways to actually avoid adversity. Your social skills. You might be an affable person who brings in adults to help support you, and then your financial resources. But those wax and wane over time. And so then it's important to us to understand what protective factors are and actually make sure kids have them as resources when they face adversity. Now, when I think about resilience, I actually like to focus on those family level and community level protective factors, because it's harder to intervene and provide those individual level protective factors, right? Those are things like how intelligent a kid is, their own self-esteem, right? Their own, how affable they are, right? But I can provide increased family stability. I actually am developing a program to improve cooperation amongst caregivers in a family. And then within the community, I can provide an array of different supports within the community that are protective factors for kids who have experienced adversity. And what we see is that these protective factors work together as part of a group, right, to improve and promote adaptive health practices in kids who have been exposed to trauma. And then finally, as we think about this concept of resiliency, we want to think about it as helping kids develop proficiency in utilizing these protective factors. Some protective factors will be more useful at certain time periods than others, but that resilience is not impenetrable. There are some adversities that are truly overwhelming for kids, and that requires us to intervene on the adversity and to prevent exposure to the adversity. But we can train individuals in the use of this resiliency process by helping them learn how to use these protective factors, strengthening these protective factors, and understanding how young kids will engage them and utilize them. And with that, I am done. So we reviewed, we talked about ACEs and how common they are among socio-demographic backgrounds, how ACEs impact outcomes across different sectors, and most important for our summit here today, how ACEs are strongly associated with substance abuse problems and the opioid crisis, the importance of broadening our understanding of childhood diversity. Unfortunately, certain populations are at higher risk for ACEs and as a result may experience disparities in health outcomes. And I think we reviewed numerous trauma-informed approaches to intervene and mitigate the impact of trauma. With that, I know I went over time. I'm sorry about that, but I hope you guys found this helpful and useful. And thank you for your time.
Dr. Wei, thank you so much for the amazing presentation. I told you, we don't think we could have found anybody better to lead off this conference this morning. Really, really powerful, sobering, yes, but hopeful as well. And so we thank you for that. I know that there are questions. I would advise anyone who has questions to stay for the breakout, because that's what we're going to do next. It's time for us to do that transition for a break and then go into our breakout sessions. I think Jessica may have a few announcements along those lines. I think we're going to have a video at some point as well during this transition for our break. But certainly think about, you may have already pre-registered for these breakout sessions, but if you have questions, we will have a breakout here with Dr. Wade as well. So Jessica.
Thanks, Joe. Just before we go to our breakout sessions, we just wanted to make sure everyone is aware virtually and in person where to find the breakout sessions. So for the virtual individuals, if you're looking to watch the keynote Q&A for a breakout session, you will stay on this link that you're currently on. And for anyone interested, you'll stay in this room. And then for all the other breakout sessions, so building resilient Black girls and addressing the needs of our children, our families, and our communities will be upstairs in room 212. And for everyone online, any of these subsequent breakout rooms will be on the second Zoom link. For the rest of the presentations, session 3, addressing the needs of our children. Session 4, the effects of ACEs on social determinants of health and pathways health response. That will be in room 246 upstairs. And then our session 5, ACEs and first responders, will be in room 247 upstairs. And again, all of those will be available on the second link for virtual individuals. We will go for a 15-minute break to start at 11. And everyone can proceed to those rooms. There's still refreshments upstairs in room 214 if you're interested as well. Thank you.
Dr. Wade, are you going to be here?
Yes, I think I'm in this room. Oh, sorry.
For Q&A?
Yes.
Hey, Dr. Wade, I'm from Philadelphia. Yeah, I was with Mike O'Brien when you first presented. Presented in Philly.
Okay.
It's all good. When I got here 3 years ago, they were talking about the ACEs study, the conventional one. And I kept telling them, I says, hey, have you guys ever Googled or learned about the urban ACEs study? I've been talking about you for 3 years since I've been down here. No, because it impacted me so much. And I used to work for an outpatient in North Philly. So I don't know if you remember, Drexel did the study at 11th and Poplar, where they have a facility at.
Right. Family practice counseling.
Right. And then Mike, I think he was in the Strawberry Mansion area because he was working with some kind of grant or whatever. Mike O'Brien.
He passed, right?
No, Mike lost a lot of weight. He didn't pass though.
Did he really?
Yeah, I thought Mike maybe. No, he's fine.
Okay, good.
Yeah, he's fine. He cut his locks and everything, but he's good. Yeah, Mike used to have locks. He used to, I remember he did one at Channel 12 at some point too. Yeah, I followed him for a long time because I have an IA score number 1.
I always do. I always don't care. Take a second.
Say they want some attention, just a few likes and a mention. Strike a pose for someone they don't know, so they don't feel all alone. In that fantasy, it ain't always what it seems. Living life on a screen, ask them what they do it for. They do it for the life, sales up for the right price, and they don't even think twice. Everybody do it for, they do it for, ooh, they do it for the likes. That blue check comes with the price, and they don't even think twice. Everybody do it for, they do it for, they do it for the likes. They post just to get views. It's not much they won't do. Filters can't hide your issues. Your old self said they miss you. And that fantasy, no, it ain't always what it seems. Living life on the screen, ask them what they do it for. They do it for the
Lying
likes.
to the light, lying for the likes. I tell you, don't be blind, they gotta fight. So many cats will try you, even buy you, then deny you all your rights. And most time they do it out of spite. I call it that blue check magic. Finest product out, everybody wilding out just to have it. Black girl magic, the tragic. It'll turn a Catholic to ratchet. Burnt out, ashes to ashes. They all fall down like leaves from money trees. So many filters, he don't recognize what he sees. Ain't no companies paying social currency. So before I fade into obscurity, I'ma do it for the likes. Cause I'll pay any price. The way my FOMO set up, I can't let up till I'm right. My whole entire life is inside of this device. And it would be so boring if I didn't roll the dice. We do it for the likes.
Sales up for the right price, and they don't even think twice. Everybody do it for, they do it for, they do it for the likes. That blue check comes with the price, and they don't even think twice. Everybody do it for, they do it for, they do it for, they do it for, they do it for the likes.
Can't garner social acceptance when I don't even like my reflection.
food for thought, finish your breakfast. But I gotta take a picture of it first to feel connection. If the gram didn't see it, it didn't happen. Keeping up with the Joneses, my greatest passion. The need for validation due to narcissistic actions. Good or bad, I'm just seeking a reaction. Imagine all value being defined by strangers, attention-seeking behaviors. Morals are endangered. Do it for the clout. Verify the counts. The lust to feel important while I'm filled with self-doubt. You can't track social capital on the dial, so I'm trying to sell you me so I can cash out. Live or die, that's the cycle we abide by. Just because you sign off don't mean it's goodbye, baby.
That's all good. I was married one time for 6 children. So we're good. We're all that. It's now she's how I came to the but the work, man, the work that ties in. It's just the person about it. So I was so excited about becoming, because I know the work and I truly, I live it, I understand the work. So once you have presentation and you understand the work, it's not just about my family, it's community. So I don't want to hold the time. I just need to, I just want to, kind of follow it today. It's great. I'm trying to really focus today. So by the time I get down, independently with the initiative I call Community Population Health and Rural Population Health in Philly, and my focus now is elders and seniors. So that's what I'm doing now. But I'll hang around. You're gonna be here. All right. So I'm gonna get back to come back.
I'm Tanika Price. I just got my doctorate and I quoted you in my dissertation.
Did you?
And I'm so excited. So can we take a picture?
Oh my goodness. Sure.
I did my study on ACEs and educational attainment in African American women. And your resource for the South critical.
Yeah, we'll have make all the slides available for the whole day to people after.
Your microphone got turned
Just
Thank you.
we have to go present, otherwise I won't
I saw
I'll go speak.
Yes, we got several questions.
Yeah. cities now.
Hello, everybody. Can you hear me? Oh, yes. We are about to get started with the keynote Q&A session. So if everybody could please return to their seats, get situated, we'll get started with that right away. And for everybody here in person, in front of you at each of these tables is a table microphone. So they have a mute and a speak button. So if you want to ask a question, make sure to hit the speak button, and then you can ask that to the group, and the people online will also be able to hear it. And also make sure that none of your folders or anything have bumped that, because otherwise the entire call can hear you.
Testing, testing.
All right. Good morning, everybody. We are beginning now the keynote Q&A session with Dr. Roy Wade Jr. For everybody who is attending in person, this is a time to ask questions of Dr. Wade about the keynote session that we just watched. And for everyone virtually, please take the time to type your questions into the chat, and I will make sure to ask the questions of Dr. Wade. To start off, we have a twofer question, actually, from the chat earlier today from the keynote. I didn't see any data presented for Asian Americans. There are Asians struggling with addiction and childhood trauma in Columbus, and I would love to see studies including Asian Americans as well. Can you share studies on ACEs in the Asian community and what culturally specific interventions you can recommend?
So, yeah, in reference to ACEs amongst Asian Americans, so clearly there have been studies showing higher prevalences of adverse childhood experiences amongst Asians. Largely, what I am trying to highlight with the work that I'm doing, that the disparities exist, right? That we know that unfortunately minorities have these experiences. And I think, yes, there can be some culturally specific ways that we can approach this, but I think largely, as I think about how we build and promote resiliency, the interventions are going to be the same, except for things like racial socialization, which are practices that help, African-American youth transition into adulthood and deal with some of the issues around being exposed to institutionalized and interpersonal racism. Largely, the interventions in terms of trauma-focused cognitive behavioral therapy, mindfulness approaches, parent support programs are going to be universal. And what I truly encourage people to do as they think about working with different populations is to engage the populations that they work with as they develop the interventions. Meaning that, one of the studies that I did was developing what we call a youth-informed adverse childhood experience measure. And for that study, I recruited young adults, ages 18 to 26, across Philadelphia who had grown up in poverty. And just in designing that measure, I asked them about the traumatic or adverse childhood experiences that they had growing up to get culturally specific details around what they thought university would be. One of the interesting findings in that study, which answers my own question from the presentation, is that instead of saying divorce or separation as an adverse childhood experience, they said single-parent homes. And when we went back to them to ask them why they said single-parent homes, which was their exact words that they used in the focus group, they said that so many of our families started off as single-parent homes that the concept of divorce and separation is something that's relatively foreign to us. But we understand what the divorce and separation means, and we could answer that question if you put it on a questionnaire. But what we know about just even administering a questionnaire is that the response, the engagement of a person with your questionnaire goes up if they can see their life experience in the questions that you ask, such that the accuracy of your measure goes up because they are more engaged with the questionnaire. So in just developing an adverse childhood experience tool to ask about adversity, it's my feeling that you have to take a youth-informed approach or a community-informed approach in just developing the questions. And I think the same for the interventions, right? I think the interventions in terms of what we want to do are largely the same. Instead of, excluding things like racial socialization, we want to make sure that young kids, Asian, African-American, Native American, Hispanic or Latino, or white kids for that matter, grow up with consistent and caring adults who are ready to respond to their needs. We want to make sure that those kids have access to things like trauma-focused cognitive behavioral therapy. We want to make sure those kids have access to programs that promote mindfulness and help them to develop mindfulness skills. But as we think about developing those programs and providing those programs, we want to engage with the population that we're serving, whomever you're serving, and how it's created, where it's administered, what's provided as part of that. The list goes on and on. To give you another example, currently right now what I'm developing is a trauma-informed co-parenting program. So not a program focused on parenting skills per se, but the way parents actually engage with each other and work together to raise kids. What we've seen from our own research is, this is something that I'm writing up for publication now, is that co-parenting skills are actually impacted by one's ACE score. How well you work with your co-parent is actually impacted by one's ACE score. And we know that if you can actually improve one's co-parenting skills, that improves outcomes for the parents, that it improves the developmental trajectory of kids. There's already an existing co-parenting program. I'm working with that person to adapt his version of that program for use with my population, meaning that I'm bringing them in, I'm having them review the modules, I'm having them review the lectures, and actually give me feedback on what they think is relatable to them and ways we can change the language and change the program to better serve them. That's what I mean, is that for the Asian population, for the Native American population, for the African American population, for whomever you're serving, you want to engage and use their strengths and their expertise as you develop whatever intervention you want to help to address trauma.
So I look around the room and see many of my colleagues who've been in the field of prevention for many years. And before the ACE study was available, we understood operating on the 42 developmental assets and resiliency. And it feels simultaneously validating and frustrating as a field to say, yes, here this is, we knew this, we've been serving these children, we've been running youth-led programs, but then at the same time, trying to create momentum and legitimacy and credibility in the field of these professionals who have dedicated their lives to these concepts. And I know you asked this later in the panel, so I'll try not to steal any of that, but I would love to hear your thoughts on broadening the footprint of prevention specialists and prevention, certified prevention consultants that can propel this work forward.
Can you give me a little bit of an idea about what you do as a prevention specialist? Just.
Writing policy. So most recently I worked for our governor and put a $20 million investment in the financial budget for prevention programs in the community. But $20 million, it's not about dollars, it's about holding the field, elevating the field, and understanding that everyone has a role to play. Right now I am the AVP at Managed Care Program, Managed Care Organization. So I'm over behavioral health integration.
All right. Thank you. So I want to take a step back first, because what you said to me also made me realize that I may not have made this clear. Those of you who sat in on my talk, you might have heard me say the landmark study, at least for us in pediatrics, right, is the adverse childhood experience study. I say that for a reason. Psychologists, I know this is not what you were saying, but I just like to highlight this. Psychologists and sociologists have known this for quite some time. Right. This only became, and I was actually talking to one of my colleagues here who's lived it, right, for 60 years, right? It's only this association with physical health outcomes that has really landed this squarely into pediatrics and primary care and to health care in general. But I talked to, when I first read the study and I was in Philadelphia and I was going around thinking about work to do, I would actually go to community leaders and I would actually go to families within the community and I would talk with them about the study. And they say, oh yeah, that we've known that for years. That's what you call it, adverse childhood experience. That's a fancy term. Like we call it this, right? We've known this for quite some time. So I don't want to suggest that somehow this is new. It's just being accepted in terms of healthcare arena. I do think that, I want to push back a little bit, that I do think that I hear what you're saying, that we've been preaching prevention for a very long time. There are individuals like yourself or in your field who've been preaching this idea around prevention for a long time. And the dollars
if I understand what you're saying correctly, have largely been going to intervention, right? And not really moving upstream, right? To like addressing some of the systemic factors, right? That lead to these poor outcomes. I think we can utilize this momentum. It took us about 25 years to take this ACE work and actually start to make it so that every pediatrician now is aware of it. And I think we now have an opportunity, right? Because as we think about ACEs, yeah, there are trauma-focused interventions that work, but, and I didn't put up this slide, what we know about the ACEs work is that we get more bang for our buck if we address the environment of the young kid, right? And their families and the environment which they live, if we make sure that that kid doesn't get exposed to ACEs in general. So I'm not sure if I'm fully answering your question, but I think that we have an opportunity now. You know, I think it's incumbent upon us to continue to highlight the importance of moving further upstream. I just actually had a colleague sit down with me to give me some critiques on the talk. And one of the things he talked about was to put it in, to steal his idea and put it in biblical terms. He talked about, Peter on the road to Damascus, right? And there being an intervention there, right, for Peter. But Peter's got to go back to that road, right, and walk down that road. And what we have to do is actually to fix that road, right, instead of to intervene. And I think it's incumbent on us. It's incumbent on talks like this. It's incumbent on policy leaders to always continue to push for intervention, show the cost benefit of prevention over further downstream in intervention. I hope that helps some.
We have another question from the virtual attendees. How can we help our young Black generation today?
Well, that's a broad question. All right, I'm going to take another road. I'm going to answer that question a little differently. You guys are going to hate this Q&A session because I'm going to take every question and I'm going to answer the way I want to, just like a politician. I think the importance is to understand the strengths they bring to the table. So and to help them to utilize the strengths that they have, right, to help create change for themselves and for their community. Now, I'm not saying put all the onus on them, right? Clearly, we need to move upstream. Clearly, we need as policy leaders and adults need to think about ways we can actually, make communities safer, improve schools, improve all the resources, provide more resources for them. But I think about even just the Black Lives Matter movement. And I think about who were the heroes of the Black Lives Matter movement. It was our young people, right? When you think about George Floyd, it was a young adult at least, right? African-American female who took the picture, who took the video that led to the cop being arrested and prosecuted, right? And who were the people who were actually walking out in the street and protesting, even during the middle of a pandemic, who would not relent until something was done about black and brown bodies and injustice in our society. I think it's important, whatever we do, as we engage and as we address these issues around trauma, that we recognize the agency and the strength of of children of color and their ability to advocate for themselves and develop ideas that actually can help improve life for themselves, right? One of my mentors, he challenges all the people he works with when we go in to see adolescent kids, because the tendency is when you take care of adolescents, they tend to ask them a question and they may slump a little bit, or they'll be on their phone, or they may not respond, in a way that you always feel is appropriate. They say things like, huh, no, things like that. But what he says is, when you come out of the room, before you say anything, right, give me one strength or positive thing that young kid has. And if you start from there, right, you find that they have an array of different skills and assets that can be utilized and built upon to create change, both in their own lives, but also in the lives of their community. I know that didn't answer the question, but I answered it the way I wanted to.
So Dr. Wade, we were talking, and one of the things I missed back in 2015 when, I had an opportunity to learn about the ACEs study as you presented it, was the importance of it starting at the level, the pediatric level that you talked about. And as I think about that, I think about folks who are women who are pregnant, as well as the young men who have been pregnant with women. And so how do we get this study and this information at that point when young ladies who are obviously seeing doctors that are coming along through their pregnancy, and prayerfully young men who have interest in their attendance, with the young ladies, and getting this information, because I think it kind of starts there. I think it could be a great start here, as opposed to, and I'm not saying it's not a great start when you have the baby and you start to visit with the doctor. Your example was that, once you understand the ACEs scores from the parents, it tells you a lot of data.
Mm-hmm.
But what's your thoughts on how do we implement that before that at the level when someone's pregnant?
So it's already happening. So I have a number of colleagues who are in the obstetrics community who are already routinely doing some form of ACE assessment or trauma assessment for the parents as part of routine prenatal care, all right? And having conversations with families around stress and trauma and how that can impact the pregnancy, and then how that can impact them as they move into parenting. But I want to push back a little bit too, because as a pediatrician, there is nothing better than that first newborn well visit. I love the fact that you highlighted the importance of dads, because dads are often lost in this picture. I've done some studies that shown that a dad's ACE score also impacts the health of a child, right? It also affects dad's parenting skills and obviously affects his co-parenting skills. So, we need to keep that into the equation as we think about trauma and as we think about trauma-informed parent support programs. But one of the unique times where I pretty much universally see a dad is when? The newborn visit. And so this is how I come into a newborn visit. People sometimes, they think I'm crazy. I walk into the room and I say, congratulations, right? Because I recognize it as this beautiful, beautiful time where both mom and dad are so excited about this new baby. And dads see this as an opportunity. Oftentimes, if you ask dads, right, they'll talk about their experience of life and how tough life was for them and how they want to make life better for that young kid. So it's a unique time to engage them and talk about trauma, right? And talk about ACEs and talk about how that can affect their parenting and how important it is to have those strong, positive parenting skills to be supportive. In Montefiore in New York City, what they started routinely doing is, this is a hospital in the Bronx, they started routinely assessing ACEs at the newborn visit, getting an ACE score for the parents and getting an ACE score for the child. Now, the ACE score for the child should be low, right? There may be divorce or separation or single parent homes, right? That'll be a point. And then there may be some substance abuse in the home, even though the dad hasn't experienced it. Or mom may have maternal depression, things like that. But a lot of times the ACE scores for the parents will be quite high, 6, 7, 8. What it affords is a conversation about why you're asking these questions, right? because the natural flow is, oh, I see you asked me about these experiences. Then the doctor has this opportunity to say, well, there have been studies that have shown that higher ACE scores are associated with, they're not set in stone, but they are associated with these outcomes, right? And there are ways that we can help you to live healthier lives and to be healthy despite these scores. There are ways that we can support you, but the conversation naturally moves to that young child and what that child's ACE score is. And the conversation then focuses on, if that child's has an ACE score of 2, how can we keep it at a 2, right? And so, you know, I want to push back a little to say, I think that newborn visit is oftentimes where you have that hopeful family in the room, both mom and dad are present. And as a pediatrician, it does create an opportunity to have a strong conversation around adversity and to really get both parents on board in terms of ways that they can keep their kids from experiencing more adversity to the best they can.
The next question that we have from the chat is, we would like to improve our culture in our hospital and emergency departments. We have a trauma-informed survey for our hospital to get a baseline of knowledge of trauma-informed care. Are there any emergency departments or hospitals that we can model? And are there any general strategies we can implement?
That is a really good question. I don't know of any emergency room departments. Obviously I know about primary care practices that are incorporating trauma-informed approaches. Once again, I don't want to make this too cookie cutter, but I think their approaches are similar, right? So one is about awareness and education. It's about making sure that every provider and every staff person, from the doctor, from the nurse, to the janitor who's just cleaning out the rooms, understands trauma and understand how trauma impacts the health and well-being of everybody who comes into that emergency room, right? And then it's about then increasing awareness, right? Recognizing signs of trauma, recognizing signs that individuals may be experiencing trauma. Also, providing people with the skills to react in a trauma-informed way, right? So in healthcare in particular, I know healthcare because I'm in healthcare. I know other organizations and disciplines do this as well. But in particular, we have this tendency to react punitively, right? When we are exposed to individuals who have been triggered and by trauma, right? So if a kid comes into our primary care practice and they're being belligerent and yelling, it's important. Like the thing I was saying, I think is so key. The first thing I recognize when a mom is yelling at me, it is highly likely that she is not yelling at me at all. You know, maybe a little bit, because I do tend to run a little bit late to some of my visits because my visits tend to be long. But I recognize that for the most part, she's probably yelling at the fact that she had to catch 2 buses to get to the practice, that maybe there's stress within the home between her and dad, that she's working multiple jobs, and that she may have experienced trauma herself growing up. And so I think the key, particularly in the emergency room where there's so much stress, there's so much that, you're talking about life and death decisions. You're talking about the place where resources are strained, where individuals have worked long hours and have limited patience. It's important whenever you engage a person, and particularly in situations where you engage a person and they're behaving in a way that you think is belligerent or caustic, to take a step back and to look at it from their perspective and to understand that it's likely not about you, and to take your own emotions and your own ego out of the equation. And so people need training on how to do that, right? On how to respond in a trauma-informed fashion, how to de-escalate situations. And that goes from the doctor to the nurse to the front desk staff, again, and to the janitor who's just cleaning the rooms, right? And then the other key about developing trauma-informed practices is this universal review of your practices and policies, going through and systematically identifying areas where you could potentially re-traumatize individuals, right? And making sure that you have practices in place that you eliminate those practices and replace them with practices that aren't triggering. And then the final piece, I think, is all about self-care. Recognizing that you stand at the forefront, right? You see trauma in its most raw fashion. And what we know is that trauma has there's this vicarious component to trauma where it impacts you and your own health. And providing supports and resources for staff, right, to help them to deal with their own vicarious experience of trauma and maintain good self-care. To me, this work and a lot of work is all about systems. I think we focus too much on individuals, right? And we don't focus enough on how we've shaped the system to help the individuals behave in the way we would like them to behave. Well, Roy, what's an example of that? All right, here's an example. All right, so as I said, in my pediatric practice, when COVID hit, we immediately, in order to socially distance, we stretched out all visits to 40-minute visits, even the newborn visit, which can be like the quickest visit, possible because it's pretty easy to do that exam. We stretched them out to 40 minutes. Now we've scrunched down visit times, even for adolescent visits, to 15 minutes, right? And I don't know who has a teenager here, but you are not going to get a teenager in and out of a room in 15 minutes. I'm sorry, all right? And so it becomes difficult, right, to respond in a trauma-informed fashion when you're pressed for time in that way. So an organizational response would be, we need to increase RVUs, right? I get it. Like a lot of, unfortunately, about healthcare is about money, right? And having the resources to keep the practice open, right? So an organizational response is, instead of making the doctors see more patients in a shorter time period, bring in more doctors or build bigger buildings, right? So that you can see more patients. Changing the system rather than making the providers work under more stressful conditions, but still provide the trauma-informed care that the families so much need in order to live healthy lives and have a good experience within our healthcare system. Does that make sense, guys?
Yeah, I don't think they can hear those mics, so let's use this one.
Press the mute one. Yeah, there you go.
Hello. Okay. I'm a school social worker, and my experience has been, by the time anybody comes to me, they have been traumatized by so many systems that they're going to appear difficult. And my experience has been that instead of interpreting somebody as difficult or resistant or belligerent, to interpret them as self-protective, because life has taught them it's not safe. So in terms of connecting with people, I'm about as white as you can get. I know that, like all my features, but regardless of who I'm talking with, that has transcended, I feel like, a lot of just seeking to understand where they're coming from and validating the fact that, yeah, life has been hard. And you've probably talked to a lot of people like me who haven't been helpful. But working in schools, I guess, and I don't know, Dr. Wade, if you can answer this, but maybe someone in the building can. Are there opportunities or forums for high-level school administration in the Central Ohio area to attend and become trauma-informed? Because I'm finding that it can be an uphill battle where I might be the only one around me who thinks like I do, knows what I do, and wants to know what I do. So a top-down approach could be helpful, because if we change our schools, we change everything.
So I can't answer that question. So there are several programs nationally that actually have gone to schools, more than 20 schools across the country, and help the schools to develop trauma-informed practices. First off, it was self-protective. I love that. That's perfect. I think that's the best way to describe it, right? One of the things that I try to highlight to people as I talk about this work is that we see patients' behavior as maladaptive. I think it's perfectly adaptive for the environment in which they exist, right? And if you put them in another environment where there's no toxic stress, there's no trauma, there's no violence, then maybe it's not adaptive. But to survive within the communities in which they survive in, it is absolutely self-protective behavior. But there's several programs. There's one program started by my colleague, Chris Blodgett, and I don't know why I'm forgetting the name of it. But his program in particular is based out of Washington State, has gone across the country and actually worked with schools, and they have a tried and true method on implementing trauma-informed practices. I discourage the use of the term or the terms becoming trauma-informed, because I think it's a process, right? Like that you keep adding to on a daily basis. And it's like most things, like you're never quite there. We all have our own challenges that we have to overcome. And so it's about being always present and aware and learning and continuing that process of learning. But their process helps the school to develop trauma-informed practices. They start at the primary level, like I said before, training staff on the impact of trauma and how trauma presents, training staff on how to respond to trauma, and then developing tertiary and secondary and tertiary programs, interventions as well. But there are at least 2 programs that go across the country and actually work with schools directly and help them to develop trauma-informed practices. I can, for some reason, the first, Dr. Blodgett's program is called CLEAR, C-L-E-A-R. His last name is B-L-O-D-G-E-T-T. He's retired, but someone else is taking over that program. It's a little expensive, but it's worked. And in San Francisco has also developed a model. I will not remember that one, but they also have a program that you can bring out, and they actually will train schools on how to develop and implement trauma-informed practices as well.
Thank you. I just was thinking that if more locally, if we had a forum for administrators to attend to bring validity to trauma-informed care. I've been asked to provide that kind of training. But I don't know that people really understand what it means or the validity, the science behind it. There's science behind this. This is not just words. It's not just fluff and hugs and no consequences.
Well, I think some of this can be virtual, right? Some of this can be training that we do virtually, with the right person leading it and developing it. But I do stick behind the idea that it has to be ongoing and it has to be sort of continue time and time again. And I think the final piece is what I said before. There has to be some, so if you look at Sandy Bloom's work on trauma and systems, right? She talks about in her work, there has to be some form of self-care that's incorporated. That's an organizational process, right? Because you're training people to open themselves up, right? To expose themselves to vicarious trauma. And what sort of supports does the organization have to help them as they experience that trauma, right? To not internalize it themselves and to hold it themselves.
And someone in the chat just posted The Deepest Well by Nadine Burke-Harris, MD, talks on some of that background information. Nadine Burke-Harris is the Surgeon General of California. And actually, this was a question that was asked during the keynote, but follows up very well on this topic. What do you think about trauma-informed students? We trauma-inform adults, and that is absolutely appropriate, but how impactful would it be if we trauma-informed our youth?
Extremely impactful. I hadn't thought about that. I think about it in general, that all people need to have an understanding of trauma, including our kids. I think we need to temper it somewhat because as younger kids, as you talk about these things with younger kids, they tend to be a little bit more concrete. But I think about our adolescents, and our adolescents are a great place to talk about trauma and how trauma impacts their health and well-being. Certainly, they get exposed to it as part of therapy that they might receive, but some form of universal practice, some form of universal knowledge and awareness, I think is a wonderful idea. And I don't know of anyone in the country who's, routinely doing that as part of their standard practice. I think it happens, so as part of my visits, my well child visits, I have I pretty consistently talk with my families about trauma and talk with young people about how the trauma they've experienced can impact their health. But I don't know anybody who's doing it as part of their standard of care.
Good morning, Dr. Wade. Just wanted to say, first of all, thank you so much for your work. We've used a lot of your work and research in a lot of ways, so thank you so much. It's great to meet you directly. You mentioned about really looking at a system level to identify areas that we potentially re-traumatize individuals. And in working with folks across Franklin County, there's concern about when we have to implement a ACE screener in a initial appointment with a client or an individual, that can be rather re-traumatizing. So curious about your thoughts and comments about balancing the value of knowing an ACE score, the value of having that information, and how do we avoid the potentially re-traumatizing conversation of talking to somebody about some of the most harmful things of their life with a stranger, and then moving on to something else within maybe 15 or 20 minutes pretty quickly.
Is it John?
Jesse.
Jesse, sorry. Can you tell me what you do?
So I'm with the Franklin County Family and Children First Council with a trauma-informed care initiative, providing training information. So we lean on your work a lot. And then our program works with infant and maternal health, first responders, schools, and really kind of generally across the board.
So yeah, that gives me a little bit better idea. I think that's perfect. Thank you. So first off, not screener, assessment, right? I'm trying to get everyone to use assessment. The idea behind that, so I conducted this study in Philadelphia at the Family Practice Counseling Network at 11th Street in Philadelphia. That served, it was sort of a family practice facility. And we actually, and I'm gonna, slap my own hand. We actually developed an ACE screening tool. A two-item questionnaire that you could give to adults. And if they responded to 97% of the adults who said yes to one or both of those questions has an ACE score of 4 or more, right? We used national data to demonstrate that. It's a pretty sensitive tool to identify like individuals who have 4 or more ACEs. And as part of that, we did some qualitative work, right, to understand the experience of the adults as they were receiving this questionnaire to try to figure out what is the best approach, right? And so we first used medical assistants and had medical assistants ask the questions. We then used a paper screener. Basically, they received the paper in the waiting room and then filled the questions out. And then we had the providers ask the questions. What do you think was the approach that the patients felt the most comfortable using? Paper and pencil. Yep, paper and pencil. Why? No. It's because the way the medical assistants ask the questions. So the medical assistants will ask the questions like, you haven't experienced emotional abuse, right? Oh, I'm just asking these questions because they're making me ask these questions, right? And actually, the patients preferred it if the providers asked the questions, but the providers would actually rush through it because they had a number of other things to do. So Jesse, your point about asking the questions and then moving on is the key point, right? Actually, when we talk to the participants about doing some form of routine ACE assessment, they were all on board. They said, about time. Thank you for doing this, right? But if they completed a questionnaire, endorsed these experiences, and the provider never said anything about it, they routinely were upset and were traumatized. If the provider asked these questions and then sort of just moved on, they were routinely traumatized. The key is that we have to equip the providers, the people who are asking these questions, on how to respond. And this is, to me, just another systems issue. Right? We walk into these scenarios and we walk into them handcuffed, feeling like I can't be human, right? I can't be myself. Our ability to respond in a trauma-informed way is just being what we naturally are, caring, supportive people. Everybody in this room, I mean, there's some training that you need, but everybody in this room can respond empathetically and say, wow, I know that must have been a hard thing to deal with. I'm really sorry that you had these experiences. You don't have to be a trauma therapist to ask these questions. And so the key, right, is that the system's got to put in the structure that allows you to be human, right? So for me, one of the ways I ask about trauma is I we don't have an assessment tool. I sort of just scan the room. And so I will look at who's in the room, and I will ask, all right, I will say, if it's just mom in the room, I say, well, where's mom? Where's dad? If it's just dad's in the room, I'll say, well, where's mom? If it's the grandmother in the room, I'll say, where's mom and dad? Why aren't they here? And oftentimes they'll say, well, mom and dad are, they have substance abuse problems, right? They're strung out on heroin, they're incarcerated, or even that they're dead, right? Then I'll look at tattoos. And oftentimes a lot of my participants, a lot of my patients, they'll have rest in peace and such on their arm. And I'll say, who is that? Sometimes my teenagers will have lockets with their dads, pictures of their dads or moms on their chest. And I will always ask, I say, who is that? That's a beautiful picture. And that's how I start to calculate an ACE score. It's sort of just conversational. But I actually take the space back, right? So I don't follow the policies. They tell me 15 minutes, I go as long as I need to. My patients understand that. They say if Dr. Wade is late, they get upset, right? But then they get an hour too, and they feel validated, right? Because I've been there. But our system's got to respond to allow our providers, right, to respond in that way and to not feel handcuffed and feel like they have to move on. Right? People have to be comfortable with just being able to sit and hold space for someone and not feel like they have to remove the burden of the experience.
Thank you. Thank you. How you doing, Dr. Wade? I appreciate all the information that you've been giving us today.
I'm doing great. I'm loving that Atlanta Braves hat. Go Braves.
Oh, okay. Yeah. It's strictly for fashion. I don't even watch baseball.
Oh, come on, man.
I like Atlanta, the city. So, so I want to ask, in terms of ACE scores, how or are there any studies that acknowledge racism and byproducts of racism, colorism, and all the things that come along with that? Is there any studies that show that people of color actually enter this world already with an ACE score? And I know you talk about assessment tools and everything like that, but would it be fair to say that some people in this country actually enter the world already having certain levels of ACE scores?
You mean by that African Americans are more likely to have 4 more ACEs than whites at birth?
Right. That is it acknowledged at birth and
yeah. So the study I quoted today supports that. There's a study out of the group at CDC that's shown racial and ethnic differences both for Asian, African American, Hispanic and Latina, Native American populations for having higher ACE scores than their Caucasian counterparts. There are individual studies looking at maltreatment, showing racial and ethnic differences in maltreatment. So I think that's universally accepted. But here's where we have to be careful, right? It's why I highlight that point and why I always sort of break down in tears as I talk about it. It's because we don't want people to go down the road of saying there's something innate about African Americans, there's something innate about Hispanics or Latinas, there's something innate about Native Americans or Asians that makes them more likely to be abusive, right? Or have houses that are stressful, right? Like we want to highlight the historical role that America as a whole has played in shaping the environment of people from minority communities, right? Even if you are affluent, right? Like even for an affluent African American, you still deal with racism as soon as you walk out of the door. You don't even have to walk out of the door. Just turn on your TV, turn on the radio, read the newspaper, read a book, right? And see how you are cast in a role that describes you as deficient, as evil, right? So we as caring people, right, want to shape the narrative for other people who might take that and reshape it and use it to label, right? This is nothing about Black or brown people. This is about a country, right, that has as a practice marginalized minority groups from the start, even before the country was even formed into a country, right?
Okay, we have time for one more question, and conveniently enough, it's one that you asked them to ask. In the chat, it was asked, why was parental separation and divorce removed from the model of the ACEs questionnaire in Philadelphia?
So for that same reason that I highlighted before. So I conducted that study amongst 18 to 26-year-olds, mostly minority, but individuals who had lived in poverty growing up in Philadelphia. It was 119 participants. We held focus groups across the city, and we essentially asked them growing up whether the adverse childhood experiences that they had experienced or that they saw growing up, and how would they describe them? What was the language that they would use to describe them? And to a woman and man, they all said single parent homes. They did not say divorce or separation. When we asked them that, we asked them why they said that. They said because that represents our life experience. We understand what the divorce or separation means, but it's actually more relevant to us to say single parent homes. Now, what that says to me is that, and I want to highlight this point, like you can actually go to studies and you can find certain studies that show that divorce or separation is actually a protective ACE, right? Can anybody give me a situation in which divorce or separation would actually be protective for a child? Yeah, domestic violence, abuse, right? And so that's what these studies show. They show that you actually take the child out of the home and the developmental behavioral trajectories actually improve because you have removed them from the offending care provider, right? So what it says to me is that it's not necessarily, and there are numerous families, right, who are divorced. I mean, what's the divorce rate in our country now? Somewhere around 50% or so, right? Kids still do well, right? So it says something to me more about the context, right? That there's context that we don't typically really understand when we think about it, right? Like as long as you, I mean, it's not ideal or optimal, but as long as the kids have supportive and caring relationships with each parent, they tend to do pretty well. And so what we said was, well, we don't quite understand this concept. We think it's something about the loss of a parent, right? That the parent's not physically there. And so for that reason, we didn't feel comfortable even putting in single parent homes because it hadn't been conceptualized well enough for us to understand how it was a stressor for kids.
Okay, fantastic. Thank you everybody for your thoughtful questions. This has been an amazing discussion, and thank you, Dr. Wade, for taking time to listen to the questions from the community and provide your insight and experience.
Thank you.
Of course. We will now be moving into the lunchtime for the summit. Lunch will be provided in room 214. That is that's the second floor, last room on the right upstairs. And for those sponsorship agency staff that will be eating with Dr. Wade, that discussion will be held in room 212. All right. And for all the virtual attendees, because I know this is the best way I can talk to you, we will be having lunch, and that will be lasting until, just a moment, that will last until 1 p.m. At 1 o'clock, we will be going back into the breakout sessions for the afternoon. That will be the 5 breakout sessions that are listed on the agenda, and make sure to move into the correct Zoom link. As Jessica described earlier today, session 1 will be the Ohio University Zoom link. It will be a different Zoom link than for the sessions this morning, but it will still be Ohio University. And then sessions 2 through 5 will be managed through Franklin County Public Health Zoom with their breakout sessions. Thank you, everybody, and I hope you have a great lunch.